Pán doktor Jan Pazour z Liberca.
This is Dr. Jan Pazour from Liberec with a functioning SCI center. Of course, a round of applause. Slovaks go to the Czech Republic to inspire what it could look like. So, doctor, please come here and give us some tips and tricks what to do. Hello everyone, ladies and gentlemen. Thank you very much for the floor. Thank you for inviting me. Yes, it does work in the Czech Republic. We have the Spinal program. Of course, there are some problems as well. I will mention those. It will never be perfect. Now a few words about the philosophy of the Spinal program. This has already been mentioned by the professor before me, and this can really work like he defined it. So the Spinal program in the Czech Republic. When you were mentioning the registers of spinal cord lesions, I think this is very important. But in the Czech Republic, we even have we don't have these registers. These are data that we collect in spinal cord injury units and SCI rehabilitation units. And despite long year efforts to implement a national register, this has not been realized yet. In the Czech Republic, here you can see the data since 2005 until 2015 about the spinal cord lesions. It is roughly the same, 250 to 300 spinal cord lesions every year. This is, the dominant categories are the C category, the H category, and the L category is the lowest. These are the data from a SCI unit in Liberec. The reasons, of course, injuries. This is a big group, but what's growing is the non-injury lesions, which is connected with the aging of the population. This is also connected or associated with the emergency, with ambulance times, with the times that the ambulance is able to come. For example, we are talking about diagnoses like the aneurysm of aneurysms, and the patients survive and they are treated with endovascular methods, but within that injury or there is the spinal cord ischemia. So this is what we can see on the chart. Since 2005 until 2015, we see that the share is changing. In 2005, injuries were very dominant, like jumps into water and so on. But in 2015, this is half and half, with non-traumatic lesions. This is also connected with the whole care. These are older patients with different comorbidities. They have, for example, internal medicine diseases or conditions. So the care that's necessary is completely different to what was needed before. Here you can see the average age since 2003 until 2017. The age changed in 2003. In the SCI unit was 38, currently it's 52 years. So we do have to take this into consideration because the spectrum of diagnosis is widening for patients who come to the SCI units. A bit about the history of spinal care. Already at the beginning of the 20th century in America, Professor Donald Monroe, an American neurosurgeon, promoted some kind of a centralization of care for spinal patients. In Boston, he founded a center for spinal cord injuries. In his publication, he said that it doesn't matter what the level of the neurological deficiency is. If the patient has a complex and high-quality care without prejudice to his disability, they can live a full-fledged life. Sir Ludwig Guttmann, many of you, or all of you know him because he's a promoter of the centralization of care as well. And he reached a huge progress in the care for spinal patients in Europe. This is a German neurosurgeon of Jewish origin who left to the UK, and there he founded a center for SCI. At that time already, he spoke about the prevention of pressure ulcers about intermittent catheterization, psychosocial rehabilitation, sports, and positioning, and so on. In our case, our shared history and then the Czech history, Professor Beneš, it's the founder of paraplegiology in Czechoslovakia. He was inspired by the work of Dr. Gutmann, and basically he promoted the centralization of care, which was unofficial in neurosurgical units, and this led to an important decrease in the mortality of SCI patients. This centralization, unofficial, was abolished, and patients had to be treated in the surgical units that were locally attributed to the given area. After 1989, it was possible to push through some efforts for the centralization of SCI patients. The care was separated into acute and chronic phase, and this was one variant, or a unipolar facility is another variant, where the patient is within a single facility from admission until they are until they go home. Thanks to Professor Venture, it was possible to open an SCI unit in the hospital in Brno. It was in 1992. It was the first, and unfortunately for 10 years it was the last as well. The capacity was not sufficient. The efforts continued, and in 1993 the government adopted a resolution which defined a spinal program. Again, for 6 years this was only on paper, but then a breakthrough came when the Czech Spondylosurgical Association was founded, and then the pressure on the Ministry of Health was increased to implement the spinal program into practice. 2001, we had a commission which was supposed to pick a facility where these units or departments for SCI patients would be opened, to also create some treatment codes and so on. 2002, this network of healthcare facilities and their areas was defined. Then the care was separated into acute and chronic, and the acute is then distributed into peracute and subacute. There were some efforts to speed up the creation of these specialized SCI units. Funds were needed for that, for the equipment as well. The 9th Academy of Zdeněk Svěrák helped, because this is how he raised money for the Paraplacenter, and he dedicated the funds for SCI units. Between 2002 and 2004, spinal units, SCI units, were opened in 4 places. In the Czech Republic, they also have the areas for which they are intended. You can see them in different colors. First was the one in Brno, which was already existing, and in functioned until 2010. It was closed, and then a new SCI unit was opened in the faculty hospital. Then in Ostrava, at the neurological clinic, the first SCI unit was opened. Then in Liberec in 2004, 3 for the traumatologic and orthopedic center, and the last was for the faculty hospital model in 2004 at the rehabilitation center. And the numbers you see there, those are the numbers of beds of the individual SCI units. SCI units are units for certain phases of the SCI. Then we also needed spinal rehabilitation units, where the patients were transferred directly, which is important, so that the care continues continuously. beds were dedicated to this in the existing rehabilitation centers in Kladruby, Košumberk and Hrabine. What was also necessary was to connect the experts who deal with the treatment of patients with SCI. So the paraplegical forum was created, and then the group for the physiotherapy of spinal cord lesions. What are the goals of these organizations? Well, there is a cooperation of the units, then they organize conferences, meetings of SCI units and spinal rehabilitation centers once every 2 years. In 14 days there will be the 12th conference of this kind. They created also treatment guidelines for treatment and rehabilitation of patients with SCI. Statistical data are also being collected. This has been mentioned already, but we still don't have the national register. So what's the current situation of the spinal program? Currently, each patient who has some spinal cord lesion should go through the whole spinal program that I will talk about a bit later. The stages of the spinal cord lesions were defined, and also healthcare facilities were specified where the patient should go. So we have the stage 1A, that's the acute state, and after the spinal cord lesion comes about, then the patient should go to one of the 15 spondylosurgical units in the Czech Republic. There is a team of spondylosurgeons 24/7 who are able to provide acute treatment for urgent injuries of the spine. The goal of this first stage is the treatment as well as the intensive care that the patient needs. So when we are talking about the treatment of the spine, we believe that timely decompression of the spinal cord can improve the outcomes of the patient in terms of the neurological conditions, also the stabilization of the spine. Then we have intensive care. Timely decompression is important. If there is some compression of the spinal cord, there is some primary injury or primary condition, but by the pressure the edema is increasing. That's the secondary condition, and by decompression we can decrease the secondary damage to the spinal cord. I mentioned polytraumas here as well. These are the most serious injuries. Of course, the priority is to save life, and then the decompression is on the lower levels of priority. The patient with spinal cord lesions need to start doing exercise as soon as possible. We need to get them to sit on the wheelchair at least, so it's quite important for the next development and rehabilitation of the patient. We always meet with a non-holistic approach, that the patient is paralyzed, that there is no use doing anything. But this is even more important, because if there are patients who don't have any spinal cord injury or damage, but they only have the spine damage, this is important. So this is really important because there are different guidelines, and we highlight this all the time. Insufficient decompression, well, you can see in the pictures what it leads to. For example, low stability, which may, for example, make rehabilitation impossible. This extends treatment and pain as well. The second task of this intensive or urgent stage is intensive care. Patients need ventilation. They may have spinal cord shock. They don't have the reflexes, so they are also at risk of nosocomial infections, then nutrition is also important. And what's also important is care. It's necessary to position the patient for the prevention of pressure ulcers. I have some pictures, but we even have worse ones. We have admitted a 30-year-old man after an injury, and this was the sacral pressure ulcer. For weeks we had to treat the patient because of the pressure ulcers, had to redress the wounds, plastic surgeries and so on, and we lost several months until it was possible to heal the ulcers. It has to be understood that if the pressure ulcer is already created, then the patient is at risk of the creation of new ones, so the whole life gets even more complicated. And the reason is insufficient care, nothing else. Now we get to SCI units. That's stage 1B, the subacute stage. As the professor said, this is until the 12th week when the spinal cord shock stops. I have already mentioned the locations of the SCI units. Here we see the number of inhabitants for each of them, and why we need SCI units. Why not transferring the patient to the rehabilitation center? Well, this is because all the complications in the subacute phase which may come about, the care is multidisciplinary, and sometimes extra surgeries are necessary, and this is the reason why SCI units are important. What are the complications? Well, there are several respiratory complications for tetraplegic patients. They have respiratory insufficiency, patients after polytraumas, for example, broken ribs, hemothorax, lack of coughing, for example, then patients with tracheostomies. And the care should lead to the fact that the patients should be decannulated. Cardiovascular patients have spinal cord shocks. They are at risk of hypertension, bradycardia, some other syndromes as well, especially for patients who have injury about TH5. And there are problems, for example, with the urinary bladder, for example, serious hypertension, serious headaches, and so on. So this is quite a serious state, and it may even be risky for the life of the patient. We need to educate them so that they know what to do and how to prevent this. Urological complications. Patients come with permanent catheter. I don't think this is the best way of deriving or evacuating urine. We are trying to educate patients into autonomous intermittent catheterization. There are some other ways which are less risky in terms of infections and urethral stenosis and so on. Pressure ulcers, we have been mentioning this already. I would like to mention the nutrition. Patients are often under malnutrition. You often don't even see this, but the nutrition is important for the prevention of the pressure ulcer, but also in its treatment. And if they have sufficient nutrition, the ulcers will start to heal, and this is also important. The nutrition is important also for muscle strength and rehabilitation. Here you can see the surgeries of the sacral pressure ulcers. Other complications, low molecular different septical complications, gastrointestinal complications, and so on. In the spinal cord injury units, we do some additional treatments. There are different fixers which were there, so we had to finish some other surgeries. In terms of the spine, patients are only treated within the acute treatment to decompress the spine and stabilize, and what we are doing is doing the front stomatectomy.
And the care, patient care, aspirational, so patients are very often out of reality, so the staff, medical staff, really has to be nice and empathetic and also resilient, and the objective is to start with moving and exercising as soon as possible. You see a specially trained team of therapeutists, and we have modern equipment, hand bikes, and you can see pictures from our gym here. Not only physiotherapy, there is also ergotherapy, so they are self-sufficient. And you can see here different devices, how to train everyday movements, motoric exercise for motorics, and exercise for operating things with their mouth. And regarding physio and ergotherapy, we have a special function. It's the instructor for self-sufficiency. We have currently the third one already. It's our former patient who became our employee and helps with physio and ergotherapy. Here are some group exercises, helps with selecting the tools and devices. So he has his own experience and he can assist in the performance of these exercises. What other staff we have? We have a clinical psychologist in our center. We have an instructor of breathe exercises. We have a kinesiotherapist and also a social worker for the first communication within the family and the social environment, but also with other staff, medical staff. It's a very complex care, and it cannot be done by one physician. There is urologist. Very often the patients have to return to the intensive care unit if they have respiratory insufficiency, or they have some sepsis. So also psychiatrists. Also, patients with tracheostomy have their special physicians. So most of the patients, what type of patients do we treat at our units? One type, one group I have described, but the second is chronic patients that have a medical condition that needs to be, why they need to be in hospital. And unfortunately, what is predominant are the bed sores and the ulcers. The second stage, that's the chronic stage. These are the spinal rehabilitation units. I have mentioned it already. Patients in these units stay there for about 5 months. In these two stages, patients like in a glass house and a greenhouse, like the plants there, we need to take care of them. They have everything they need. They are surrounded by support. But then it's the tertiary phase that's returning back to the reality when the patient is out in the street. And you could see the picture with the stairs. You have barriers everywhere. Patients then, there can be social isolation, family relationships not working, and of course they can work continuously on the return to the reality to make it smooth. However, it still remains a problem. What type of non-profit organization play a very important role in this phase? In Czech Republic, there is a Czech Association for Paraplegic Patients, and these are the organizations where patients can turn to. They can be psychological, social rehabilitation. There can be some states, some sport activities. They can stay there somewhere. They are publishing some information and giving counseling. This is very important for the tertiary phase. And in this phase, also spinal units play an important role here, because we have an dispensary counseling workplace where all the patients at least once per year are required to come. It doesn't happen all the time. Currently, patients, we counted, it's just 1/5 of our patients who return. We don't know of the others. So we are really trying to make this counseling as complex as possible. So there is not only a physician, there is an ergo and also a physiotherapist and therapist. What is also important that they have their GPs, they have their urologist or some other expert physicians that are needed. So to conclude, the spinal program in the Czech Republic works. However, there are many challenges, of course. We have already mentioned the register of the spinal cord injuries. Then this dispensary counseling works partly and tries to motivate the patients to return and to come to make this dispensary more effective. And it's also to prevent complications, to react in an early phase of possible complications, and to prevent pressure ulcers. Small problem is also informing the broad public. We know patients on wheelchairs. We know that these people, let's say, are a problem for many doctors. They don't know how to handle them, and very often then the care is not sufficient in smaller medical facilities. Then also the capacity of the SCI units for chronic patients is also a problem. On the waiting list in Liberec, for example, we have 8 patients waiting for plastic surgery of their pressure ulcers. So the 8 on the waiting list can mean the last one, it's a long waiting list, 1.5 years for a surgery, for example. I mean, you might know Jirka Suchanek, and he's a successful patient of ours, and he's a successful athlete as well. And this example is to motivate the patients with spinal cord injuries to work so they can continue in their lives and be successful. So thank you for your attention. Doctor. We always say that neighbor's grass is greener, so we are a bit envious. What would you recommend Slovakia? My feeling is that it was already defined and introduced by the professor. The way how he did it, I think it's copying the system of the Czech Republic. So you could see, yes, it's a long way. It took a long time also in the Czech Republic. It's working with authorities. But I think this is the essential part of it, to convince the authorities that these patients are here, they need care, and there are results. When the care is complex, then there will be results. So as long as the patient wants it, they can live a full life. And that's also the reason or the sense of it. Yes, so you have to fight bureaucracy. Yes, yes, and this national registry of spinal cord injuries. It was planned, but then it was cancelled. So yes, Mr. Pazour, Dr. Pazour, a big applause again.